My name is Shane Miersch. I am a biochemist by training, and I was in the United States doing a postdoc specifically looking at autoantibodies in diabetes, and so started to work with various proteomics platforms for screening human serum and trying to identify what antibodies were there that happened to target human proteins anomalously. And so this was kind of the time in which I started to acquire an interest in antibodies and their role in normal physiology and disease physiology, and then also as just in the very nascent stages of therapeutics. And so in looking to come back to Canada, one of my mentors there had mentioned that he had a friend who was often looking to hire, and maybe I should reach out to him. And that's when I was introduced to Dev, to his lab, to his work, to the sort of things that he did, and it interested me. And I understanding that he worked primarily in antibodies, but developing those antibodies, I saw this as a kind of open-ended opportunity. Antibodies are not going anywhere. They form an increasingly large segment of the pharmaceutical industry, and I thought this is an area that I think I could make some impact in. And so I joined the lab back in 2010. I've worked with him now for over 15 years, and in the last few years, increasingly shifted from mere discovery of antibodies into the engineering of antibodies into multivalent and multi-specific formats. So this is based upon the recognition that antibodies are modular. That is, they are comprised of components that can be expressed independently from the overall structure of the antibody, and so those independent components can be refashioned into new antibody-like structures. And so this is really the focus of our work now, is how do we take antibodies that we discover in the lab and refashion those into entities, single molecules essentially, that can be used to treat disease. And so the first scenario in which we demonstrated that they had utility above and beyond that of the conventional IgG type antibodies that the pharmaceutical industry primarily focuses on was in the context of COVID. And so when all the university laboratories were shutting down, the university essentially said, if you're not working on COVID, you need to shutter the lab. And so we pivoted, as many people did during COVID, to work on COVID. And that was really the first instance in which I saw a project go from the very early discovery stages of novel antibodies to the reformatting, to the testing of those in vitro, to the testing of those in vivo, and then moving towards being able to manufacture them. So for us, it was a pivotal, in many ways, first demonstration that these could be produced, that there were advantages to them in the context of engineering potency, and also in the context of viruses, enhancing the breadth of specificity. So, for instance, as we realized that the virus was continuing to mutate, and by virtue of mutating was escaping some of the antibodies produced both within the body as well as outside the body as therapeutics, we saw an opportunity there to devise and engineer these for exquisite potency and high breadth of specificity. So that was really where this story starts in many ways, and the story continues now until this day, where we're using these antibodies in these formats that we've devised, these multivalent, multi-specific formats, to target a whole host of diseases, including viral diseases, viral infections, oncology, and also regenerative medicine. So it's become very interesting now because this is a versatile technology that we've developed, and we're one of the first groups to really explore and push the limits of what can be done with these. So it's an exciting time, and of course, seeing your work as a scientist, seeing your work going from development on through optimization and then into the clinic is probably one of the most rewarding things you can do, is seeing your work have real world impact. And so that's kind of where we're focused right now, and continue to put the vast majority of our efforts is really pushing the boundaries of what can be done with multivalent antibodies, exploring the properties that emerge when you combine multiple antibodies into a single entity. There's been some surprises, I would say some serendipitous surprises along the way, and some very interesting features of these that we're still exploring and discovering. So in a nutshell, in a quick and dirty summary of 15 years of worth of work, that is in essence what we do. So RSV is actually, it's a respiratory infection, a viral respiratory infection that was really kind of a teaching moment, because that was the first time, that was the first disease for which an antibody-based therapeutic had been devised against a virus. So even back in the 1990s, it was recognized that RSV was a problem, was an issue, and then a drug company intervened with an antibody that targeted that virus and inhibited its reproduction in vivo. So fast forward, let's say 25 years roughly, it was approved in the 1990s. Fast forward 25 years, and realized that drug was actually quite a poor drug. It was expensive. It had to be dosed multiple times over the course of a season. So let's delve back into RSV as a disease. So this is a viral respiratory infection that primarily is a problem for young children. Virtually every child before the age of 2 or 3 years old will have an RSV infection because it circulates annually and seasonally. And so really in both young children and aged adults, it poses the major problem, is because they have either they're immunocompromised, they have limited ability, or they have comorbidities. Children don't necessarily have the immune system to be able to deal with that effectively, and particularly children with congenital issues like cardiovascular issues can pose a real threat, and hospitalizes up to 5% of young children in the first couple of years of life. So really, an antiviral antibody to RSV was envisioned as a prophylactic, something that could be used to treat young children before they got infected, recognizing that they would almost certainly be infected in the first few years of their life, and either prevent the infection or limit the severity of the infection. So since the advent of that drug in the 1990s, it was recognized that the drug was not great. A couple of different drug companies had demonstrated this and said, okay, 25 years later, we have something better. And now there are 2 drugs that have been recently approved to treat this, but we've realized that there's still liabilities and limitations to these. One of the things that people have been advocating for, pediatricians in particular, is that every single child be treated prophylactically to prevent infections or severe infections. And unfortunately, because of the cost of biologics, even though they improved the drug, it wasn't sufficiently improved to warrant treatment of all children. So the American and Canadian Pediatric Societies still advocate for all children being treated, but the economic realities of it limited to only those children who are at particular risk. So we saw an opportunity there in that we can engineer antibodies and improve their activity. We saw an opportunity to take these existing antibodies and refashion them into multivalents that specifically enhanced both their potency and their breadth of specificity, similar to what we had demonstrated with COVID. And so the idea here is that if we can sufficiently improve the potency and breadth of specificity of these antibodies, perhaps we can reach that point in which we can prophylactically treat all children. And the reason that that's important in treating them early on in life and preventing the severity of those early infections, we also hope to prevent some of the sequelae, some of the later on, the knock-on effects of that infection, which can predispose them to asthma later on in life or other respiratory problems. So this upfront cost of prophylactically treating children, we think in the long term would be recouped by diminished downstream hospitalization and the necessity of treating individuals later on in life. So that's one side of it, if we can improve it sufficiently to treat all children. We also realize that RSV infections, there's often outbreaks in long-term care centers. So the other side of the spectrum is that the aged population is susceptible to this. As you get older, you have respiratory problems, other issues. That can also cause major problems in long-term care centers and hospitalize individuals and cause mortality as well. So we're looking at ways to improve it for treatment of elderly populations as well. And that's largely, we think the drug that we have currently is fairly good. What we're trying to do is increase the solubility of it so that adequate quantities of that can be administered to an individual. So one of the upsides of this particular drug in that instead of having to administer the drug intravenously, as many therapeutic antibodies are, what they've shown in children is it's possible to administer this intramuscularly. So instead of having a nurse and having an inpatient sort of a situation where a patient has to come in, a nurse has to put in an IV line and then administer the drug over a period of time, it's a single shot into the leg or the buttocks or something like that. And it's sufficient to prevent infection. And so we thought, well, if we can increase the solubility of this drug, we can also then administer sufficient quantities of that to the elderly population, which is not possible with the current drugs right now. They're not actually approved for that particular indication. So there's a couple of ways we saw through advanced engineering techniques that we could improve the existing drugs for either broader population suitability, or in the case of elderly people, for a new population that isn't currently treated in this manner. So we see that there is not only an unmet medical need there, but an opportunity and markets for a drug that has not yet been opened up. These are not necessarily cheap drugs, but we're trying to improve the effectiveness of those drugs and reduce the cost sufficiently so that it is not so prohibitive and that people could broadly access a drug like this. So one of the things that we do is that we improve existing drugs on the potency side. So when you increase the potency, you reduce the amount that has to be administered. And by reducing the amount that has to be administered, you're effectively reducing the cost. So that's on one side of it. On the other side, there's the opportunity. One of the primary considerations that we focused on in developing these novel type of antibodies and reformatting them is that you still have to be able to manufacture them in the same way that you do a conventional antibody, and so there are certain production yields that you expect, and we've been able to both engineer these novel antibody formats while maintaining their manufacturability. So the yields that you get from them, their ability to be purified in high purity with relative ease, and so these things combine together to reduce costs. Not only increase potency, but if we can also increase yields or at least maintain yields, there's been a lot of effort being put into increasing biological yields from production cell lines in general. So we think that as time goes on, combining our technology with the technology of others will eventually help us to bring these costs down and make them more accessible for people. And this has been a big priority for us. It's kind of a social justice issue, is that people have access to these drugs, and they're not just drugs intended for those who can afford them. I would say, and Deb would probably give a very different answer, may give a very different answer from me, but I think in part, given this kind of interim situation that we happen to be in, where we're no longer at a university, we no longer have access to the sort of institutional support that people within the academy would have. So we have to look at things in a realistic manner, and that unfortunately involves the economics of the situation, is that we have to focus on projects that we think that, at least in the short term, while we still have existing funding from the sources that we do, will give us a win and start to generate some revenue. As a nascent company, we have no revenue, essentially. And so in part, it's projects that we think that we can improve upon existing drugs where there's already a market in place, and then supplant that particular drug, essentially taking it over by making bona fide, demonstrable improvements in a drug. In part, it's where our interest lies in the tools that we have at our fingertips right now, which is increasingly broad. So we do have a large portfolio of antibodies, and over the years we've focused largely on diseases where there is an identified target that is clinically validated. So these are things like, for instance, breast cancer, HER2, that is a target that has been clinically validated. Lung cancer, EGFR, that is a target that's been clinically validated. Things we talked about like PD-L1, this immune checkpoint blocker, that is something that has been clinically validated. And so we have the advantage by virtue of our technology and being able to combine these things together is to take molecules that are already to some degree clinically validated, combine them, and hopefully get a quick win. So, obviously in the long term, if we're able to establish ourselves scientifically and economically as a company, there is the opportunity then to work on projects that we're merely interested in, maybe things for which there is no market, there is no drug, but we think that we have the insight that we can develop a drug. But that's a much higher bar, because there's a lot of biology that has to be demonstrated, and you don't necessarily have the benefit of having a pathway that's already been blazed by former scientists and developers and companies towards bringing a drug to market. So those are some of the considerations that we have to contend with at this stage, and it's just part of the reality of this is a new company that we formed. We have lots of tools at our disposal, but we also have to move quickly because science is expensive, and the money that we do have to support this effort will not last forever. So we've set ourselves a fairly rigorous timeline of about 2 years to advance as many things as we can to a point where they have some value in the eyes of investors who may want to come in and put money into that to continue the clinical development, or where we can actually fund the further clinical development ourselves. So it's a challenging time, but it's also an exciting time. So for instance, like in breast cancer, it's known that this target, it's a receptor tyrosine kinase called HER2. And this was one of the first antibodies that was developed against a target in the context of cancer. And it was a game changer for about 30% of women with breast cancer who overexpressed this particular target. Treatment with an antibody against that was effective. But it also shows the limitations of what a single antibody can do. Beyond that, those antibodies are ineffective. So we look at it as a situation, well, yes, we can evaluate a particular type of cancer and see what targets are there, understand what targets may have an influence on the development of the cancer, and then combine those things into a single antibody for treatment to see if we can improve upon the efficacy observed with that original antibody. And so this is part of what we do. It's kind of like taking whether we already have a foothold, where we already have an understanding of what drives the disease and the limitations of that disease, and then trying to find a molecular strategy to overcome that limitation and push the boundary further. The macular degeneration drug actually poses, no, it was not like that, in that the particular mechanism that is used, an understanding of that disease and the way that it's treated, that's usually most often treated with an anti-VEGF. So macular degeneration, a portion of that disease comes from vascular dysregulation. And so when you have a disorganized, leaky vasculature in the eye, that's one of the things that can contribute to blindness. But that's not the only thing. You also have a loss of cells in the retinal epithelial barrier there. And where existing drugs may protect from further vascular dysregulation, they don't reestablish that retinal epithelial barrier. And so where the current drug that we have in clinical studies for AMD comes into play, it actually looks at this in a very different way, in that it's no longer looking at just vascular degeneration, but how do you actually regenerate an epithelial barrier that has what we call vascular integrity. It's not a leaky barrier anymore. So that was one of the, of course, that drug came out of 15 years of research in the university setting, where we had the opportunity to take chances and some funding that was coming in continually, where we could explore a novel biology rather than trying to latch onto an existing biology that was already clinically validated. They developed a drug that targeted a novel biology. And the interesting thing is now those drugs can be used in tandem, possibly. You know, one drug to prevent the vascular degeneration, the other drug to essentially reestablish the retinal epithelial barrier. So I would say that's a much more substantial advance, in that we're not looking for that kind of piecemeal, can we just tip the needle a few more degrees here and improve our ability to treat this disease. So yeah, that was a very different drug and came out of a different scenario. That's, you know, hopefully we'll have the opportunity at some point, if we can get this company stable and to a point where we have a little bit of extra money to look at novel biology that isn't necessarily being used for treatment now. One of the things that came out of that particular project really relates to the specific way that we look at science and drug development. And we like to use this term called systems biologicals. And so I often have to explain this in the course of talks that I give to people. Systems biology is really a perspective and an approach to characterizing a cellular function or disease in a very comprehensive manner. So it tends to take multiple different ways of looking at a disease, for instance, genomically, epigenomically, proteomically, transcriptomically, and looking at that on a global scale, and then combining those insights together to get a really comprehensive understanding of a system and how it functions. Now, we've adapted that idea of systems biology to this idea of systems biologics. Instead of, say for instance, the conventional drug development path has been, here's the target, we're going to work on this and see how far it will take us. We tend to look at it on a more comprehensive level. So say for instance, we tend to look at a family of proteins all simultaneously. So, for instance, one of the families of proteins that was targeted in that during the course of developing that drug for acute macular degeneration actually has 10 members in the family. So instead of saying, trying to guess at which one of them we should be working on, we said, well, let's work on all 10 of them, and we developed things that were specific for each and every one of them. So now that allows us the opportunity with this new multivalent technology to take each of those single target specificities and focus on that, and then do this in parallel and try and figure out, well, which one of these family members is really the one responsible for this particular disease. So in developing the drug for acute macular degeneration, wet macular degeneration, we identified essentially a single drug based upon one of those targets in combination with something else. But now we have essentially the same antibodies for 9 of the other family members. So this is an area where, again, it's open biology. We really don't know how these things function because we've only now just developed the tools to look at them independently and probe them independently, which is necessary for science to advance. The reality is that in the past, there's always been cross-reactivity between members of the family, and that even the natural ligands that target those members of the family are promiscuous. They bind multiple members of the family. So there's no way of identifying and really drilling down to the molecular origins of a disease. Now, in the course of the development of this drug, we have antibodies that target each and every one of the family members independently. That creates the opportunity to probe them independently because they may have different roles each receptor may have different roles in different parts of the body, and we have to explore that biology to figure out, well, how can we drug this target? What is the most appropriate way that is going to be both safe and effective? So it's been a very it's a learning process, I think, and also an opportunity to kind of wade into new areas and really, I don't think with some of the tools that we've generated so far, there's probably another 20 years worth of inquiry and development before we realize, well, what are these things that we've developed going to be useful for? And the reality of that is that because of the financial constraints, it's like we developed all those tools, but then at one point we sold all of those tools in the hopes that putting them into somebody's hands who has deeper pockets than we do can then explore and use those for development of new drugs. That doesn't prevent us from continuing to work on it, but it does bring some money in that provides us the ability to do the sort of work that we're doing, but also puts those tools in somebody else's hands so that they can explore. And I guess in some ways that's the beauty of science. You create things, and you don't always know necessarily what the application is going to be down the road, and you're not necessarily the person who's going to figure that out. The beauty of science is that we do like to publicize these things. We do like to put them in other people's hands because people do things differently, creatively. They have different insights, and they may do something that we would have never thought of doing, and then come up with an application or an indication for it. When you sell those, you just can no longer commercialize them yourselves, but you can continue to work with them at a research level, and then also we can continue to work on them if we develop new things against them, which is entirely possible.